at least 6 clinical trials have reported improvements in depressive symptoms over the last 15 years. Now, most of these include 1 to 2 administrations of psilocybin. And so this ego dissolution, the feeling of kind of letting go, however temporary, can be extremely profound. So the medications currently prescribed are largely based on the monoamine theory. The monoamine transmitters are serotonin, norepinephrine, and dopamine. There is little to no difference in the efficacy when comparing all the major psychotherapeutic interventions. A lot of what drives really any unpleasant thought or feeling is simply the identification with it. Sometimes it's necessary to act something out before you can believe it to be true. What's more important to our sense of worth, i.e. what we tell ourselves about ourselves, is more closely related to the direction in which we're heading than the place in which we currently reside. Depression in and of itself is a mental state, which is very broad. Depression is often used synonymously to encompass a range of depressive disorders. These are disruptive mood dysregulation disorder, major depressive disorder, and this will include the major depressive episodes, persistent depressive disorder, which was previously known as dysthymia, premenstrual dysphoric disorder, substance-induced depressive disorder, and other specified or otherwise unspecified depressive disorders. This video will largely be related to these. It will not cover manic depression, which is depression associated with bipolar affective disorder. It will also not cover the severe depressions with psychotic features, suicidal ideations, and catatonia. This will often require additional management initiated in hospital settings. This may include, and the reason I say this is because I will not elaborate on these further in this video, ECT, augmentation with antipsychotics or mood stabilizers, psychostimulants, and other controlled medications. There are also other medical devices that are sometimes used, mostly in the US, for these cases, which I won't be going into further. When patients present having recently experienced or still experiencing unfortunate circumstances such as loss, unemployment, I will always emphasize to them that this is not the psychological problem. It's an actual problem. The depression that results was often a reaction to one or more situations that was either maladaptive or excessive in nature. And then after some time, this can often result in what would be defined clinically as a major depressive episode. But the situation or the situations which prompted the reaction in the first place often persist. And in actual fact, what I normally see when assessing someone with when I assess somebody who's experiencing a state of depression, is what was initially or still is something that it more closely resembles something that is often referred to as adjustment disorder with depressed mood. Now, the difference between major depressive episodes, which occur as a result of or a response to acute stress, and adjustment disorder with depressed mood, broadly speaking, is the severity of the episode, and it's not necessarily the causes or even the long-term prevention. The reason I state this is because we all vary in the way we cope and respond to stressful situations. And some of us are blessed with this amazing ability to manage acute stress or even just live a comparatively fortunate life where we're exposed to less of it. Regardless, there is still no escaping the fact that there are still fundamental lifestyle or even behavioural factors that we all need to attend to in order to maintain a remote level of psychological stability. And often, especially for more severe and long-standing depressive episodes, these fundamentals have been absent for a long time. I guess I say this because it always pays to be especially cautious not to over-medicalize things, in the sense that it's our sole priority. I'll go on to these fundamental factors later, but first I'll go on to explain the gold standard medications used currently to treat depression and what it is exactly that they do. So a quick disclaimer before I move on. Coming up, I list a multitude of supplementations, medications, and the research on them. This is an educational resource that serves to inform. These are not practical steps you should be doing independently. To do this, you should always consult a qualified clinician. So the medications currently prescribed are largely based on the monoamine theory, which basically proposes that it's the insufficient activity of the monoamine neurotransmitters, which is the primary cause of depression. So these monoamine transmitters are serotonin, norepinephrine, and dopamine. Now, this theory has been called into debate recently, and I think for good reason, as really the rationale behind solely pursuing this as the pathology of depression, I would say is questionable. Thankfully, the emerging treatments are beginning to involve other systems that are shown to play significant roles in the pathophysiology of depression. With all that being said, that there is still no doubt that the antidepressants that are prescribed currently that increase the availability of these particular neurotransmitters are still beneficial for most, with a meta-analysis performed recently looking at the effects of 21 different antidepressants and their effects that they had on major depressive disorder. That there is a clear advantage when taking these when compared to placebo. So although there is obviously much more to the cause of depression than simply these particular neurotransmitters, there's still no doubt that the abnormalities in the transmission of these networks plays a large role. As previously mentioned, the monoamine transmitters are serotonin, norepinephrine, and dopamine. Serotonin generally relates to our mood, and in depression, the depletion of this will generally equate to the low mood or guilt or feelings of grief that's often seen. Norepinephrine generally relates to our energy levels, and the depletion can often equate to exhaustion. And dopamine generally relates to our motivation or our ability to experience pleasure. And in depression, the depletion would equate to what is normally seen, which is anhedonia, or a lack of motivation and ability to experience pleasure. So all of the current antidepressants interfere with one or more of these particular neurotransmitters. Now, these antidepressants are SSRIs, so that stands for selective serotonin reuptake inhibitors. I would say these are the class that are most commonly prescribed. SNRIs, which stands for serotonin noradrenaline reuptake inhibitors. And examples of these would be venlafaxine or duloxetine. Then we have the atypical antidepressants, and the main ones are bupropion, which is it's a norepinephrine dopamine reuptake inhibitor, and mirtazapine, which is complicated. It essentially leads to an increase in the release of norepinephrine and serotonin. No consistent differences in safety or efficacy have been shown between the antidepressants. And so the choice of the particular antidepressant should really be informed based on other factors, such as side effect profiles or even the nature of the depressive episodes. For example, if concentration and energy levels are concerning, I would say an NDRI or SNRI might be the first choice. And say if insomnia is present, mirtazapine may work because of its effects on histamine. Or say if weight gain is concerning, then potentially some of the more stimulating SSRIs, such as fluoxetine or others, may be helpful. So future research is now directed towards something called pharmacogenetics, which is interested really in identifying the genetic differences which give rise to the varying improvement and also the side effect profiles that differ between individuals with the same antidepressant. At the moment, it's largely, it's a guessing game at the moment as it relates to, starting the appropriate antidepressant. I guess if any of you are struggling with trialing antidepressants, and when I say this, I'm referring mainly to kind of starting and stopping different types because of either the side effects or just that they weren't effective, don't worry, you're not alone. It normally does take a number of attempts trialing different antidepressants to find the one that may work for you. And like I said, this is as it stands, and hopefully this will all improve. When it comes to psychotherapy, the first line therapies are CBT, so i.e. cognitive behavioural therapy, and IPT, which stands for interpersonal therapy. I want to emphasize the evidence is clear that there is little to no difference in the efficacy when comparing all the major psychotherapeutic interventions and how effective they might be. Now, CBT and IPT, they're not first line due to them being more effective than the others. There's this common misconception that because something has the most evidence, that this somehow shows that it's the best, and this isn't the case. CBT is a great therapy and one that has a growing body of literature that really points to its efficacy. But the large evidence base is purely a consequence of, well, for one, that it works, but also the money and attention put towards the research of it. The efficacy of one thing doesn't prove the inefficacy of another. And when looking at the large studies that have compared the main psychotherapeutic modalities, there's little to no difference in the therapeutic effects between them in terms of their effectiveness. I'll do a separate video demystifying the psychotherapeutic approaches at another time. But for now, put simply, it's the preference of both the therapist and the recipient, which has the largest impact on the effectiveness of the treatment. With that in mind, I'd urge you instead to have a read about the styles that you think may be appropriate for you and may suit you best, and also the type of therapist that you would feel most comfortable with, and then just go from there. Just a slight caveat, I would like to very briefly touch on the mindfulness practices, as in the West, really ever since John Kabat-Zinn in the 1970s, a lot of therapists will now often introduce this practice alongside other conventional therapies. These work most effectively, if we're going to talk about depression, in dampening the cognitive component to depression. Thoughts of panic and grief and the kind of negative ruminations that I previously alluded to. Now, a lot of what drives really any unpleasant thought or feeling is simply the identification with it. It's the intimate association we have on an almost continual basis with the content of our minds. And often the root to much of our suffering, and this is especially true with specifically the cognitive aspects to depression, is based on this. And so the ability to detach from this negative self-talk, common in depression, it comes with deliberate practice, and this is most reliably delivered in the form of mindfulness meditation practices, and mostly because it just allows you to set aside some time in the day to actually practice this task of not being identified with the content of your mind. So next off, the emerging medicines. There is a growing consensus that there is a need for more effective antidepressants, and the new treatments being trialled that look promising all relate to the following mechanisms. So they either interfere with the pathologies in the monoaminergic systems, which were mentioned previously, and these monoamines are serotonin, dopamine, and norepinephrine. They also look at interfering with the emerging understanding of the role that inflammation plays in depression. They look at interfering with the emerging understanding of the role hormones play in depression, and specifically the thyroid hormones, the sex hormones being specifically testosterone and estrogen, and the hormones relating to the HPA axis involved in the stress response. And the most well-known one would be cortisol, and this has a lot of interplay between it, states of inflammation as well. They're looking at inducing plasticity as well as a possible cure, and this would be inducing plasticity of the neuronal networks. And this is based on the observations of depression as being a state of a reduced ability to make the appropriate adaptations to stress or negative thought patterns. And lastly, the treatments are looking at interfering with the emerging understanding of the role that the glutaminergic system plays in depression. And this is the system that regulates another neurotransmitter named glutamate. Now, glutamate is the most abundant excitatory neurotransmitter in the brain, and the varying levels of it have been correlated to states of depression. Now, first off, there's dextromethorphan and bupropion. Now, the bupropion was mentioned earlier. Now, this is a combination of dextromethorphan and bupropion, and dextromethorphan is a glutamate modulator. This has shown to be very effective in trials, and it's currently licensed for major depressive disorder in the US. Now, trials that have been done so far have demonstrated that it is more effective than bupropion alone, which is the NDRI. An additional point is that the therapeutic effects of this medication have been observed within 1 to 2 weeks of starting the treatment and sustained following this. And seeing as most current antidepressants often take a minimum of 4 to 6 weeks to take effect, this is a really reassuring finding. Next up, we have thyroid hormones. So a small amount of evidence so far has shown that the administration of either T3 or T4, which are thyroid hormones, can be effective when given to those with treatment-resistant depression. And these are those with depression that even then still have normal thyroid levels, and T3 and T4 have been shown to be effective even in these circumstances. Next, there's Botox, which is most widely used for cosmetic purposes. Interestingly though, there has been a recent exploration into its potential effects for those with depression. The studies performed have been quite successful in that they have consistently shown a reduction in symptom severity in those with depression that have received Botox. Now, there's likely a number of explanations at play here, and I don't doubt that confidence could play a large part. But the major theory into how it might be effective is actually in relation to the reduction in the negative feedback from the face that occurs after a Botox course. You may have heard of the knowledge that smiling makes you happier. Well, it's the same kind of thing here. Botox here essentially reduces the ability to frown. Next, there's ketamine. So ketamine is a dissociative anesthetic. Its use in major depressive disorder is at lower doses, and it's delivered intravenously. And it works primarily here as an NMDA receptor antagonist. Now, most evidence demonstrates that its effect at alleviating symptoms of depression is rapid, but it's also short-lived, with the positive effects usually diminishing at roughly 2 weeks after a single dose. So because of this, obviously its utility is limited, and really the interest in ketamine in this field is more so in relation to what it is exactly that makes it so effective, being that it works on completely different pathways and in different ways to the existing medications. And it's thought that its antidepressant effects are due to its effects on promoting neuroplasticity. Now, this brings me on to the next emerging treatment, which likely works via its effects on also promoting neuroplasticity. And this emerging treatment is the psychedelic compound psilocybin. So when ingested, the body quickly converts psilocybin to psilocin, which is an agonist at multiple serotonergic receptors. And it's got its highest affinity towards the serotonin 2A type. First, I'll go into the results from these studies to date, and then I'll explain how exactly we think it's so effective. So at least 6 clinical trials have reported improvements in depressive symptoms over the last 15 years. Now, most of these include 1 to 2 administrations of psilocybin and supported psychotherapy. Now, these studies are pretty consistent in that there's a significant improvement in depressive symptoms reported and observed by the subjects. What's even more promising is that these effects are long-lasting, with the follow-up studies now demonstrating the significant reduction of symptoms recorded persists after 12 months. In terms of success rate, I'll refer to the most relevant study, in that it was pretty recent and done specifically on individuals with major depressive disorder, and it was also a high-quality randomized controlled trial. Now, in this study, 71% of the participants on both week 1 and 4 after treatment experienced a reduction in depressive symptoms by over 50%. And of these, 54% of these people experienced complete remission, meaning they no longer fit the criteria for clinical depression. This is obviously very impressive. Psilocybin is most commonly known due to it being the active compound in magic mushrooms, and the effects following the ingestion of psilocybin are commonly referred to as a trip. Now, the acute subjective changes, so i.e. the kind of perceived experience during trips, are usually that of a significant change in thought pattern, behavior, and this really unique experience of ego dissolution. And when I say ego dissolution, I'm referring to this experience of the perceived boundary that we all have between the self and the world that we inhabit. And during the trip, this momentarily breaks, or at least becomes less apparent. This in and of itself can be extremely profound as an experience. Like, most of us live our lives holding on to this self-constructed identity of ourselves. Some of this sense of self is necessary to play a role in our daily life, but a lot of it isn't. And it's exactly this sense of self, which is, well, here used synonymously with the ego, that is responsible for the boundary that we perceive to be, well, to be present between us and the outside world. It's this disconnect between our ego and everything outside of it that often causes, or at the very least heightens, the mental suffering that we often endure. And so this ego dissolution, the feeling of kind of letting go, however temporary, can be extremely profound. That's the subjective experience reported, but what's my main concern here is how exactly this compound manages to induce these long-lasting effects that persist far beyond the metabolization of and excretion of this particular compound. Now, the only feasible answer to this relates to neuroplasticity, which is, in other words, just the structural and or functional change of neuronal networks that were responsible for the previously depressed states. So how exactly neuroplasticity occurs in psilocybin? Now, neuroplasticity, as we know, simply put, is just the ability of the neuronal networks within our brains to change through growth and reorganization. It can do this functionally in the ways that the neurons behave, and also structurally in the way that the neurons are structured. So our neocortex is composed of 6 layers, and psilocybin stimulates the 5-HT2A receptors, or serotonergic receptors, serotonergic 2A receptors in layer 5 and 6 pyramidal neurons, and as well as the GABAergic interneurons. Now, the net effect appears to be the excitation of layer 5 pyramidal neurons, and because of this, increased levels of the neurotransmitter glutamate. And this results in greater stimulation of a particular type of glutamate receptor, named the AMPA receptor. The molecular pathways, such as the mTOR pathway and others, which follow after the stimulation of this AMPA receptor, is outside the scope of this video, as it gets very technical. And I also appreciate that I'm venturing dangerously close to mechanisms that I have relatively basic knowledge of. What I will do is link the studies below for those who are interested in the details. I have read it though, and really the takeaway is that this AMPA receptor stimulation triggers a positive feedback loop, which leads to a sustained AMPA activation. And it's this sustained activation of both the AMPA receptors and mTOR, as well as the activity of the serotonin 2A receptors and other glutamate receptors, which appears to be necessary for this enhanced neuroplasticity that continues to occur following the stimulation with psilocybin. Now, the neuroplastic effects, they remain local to the neurons stimulated that express these serotonin 2A receptors that psilocybin initially activated, because the molecular pathways that triggered act locally in the place in which they started. Basically, what this means is that the structural and the functional effects that psilocybin might have on the brain circuitry is likely to be in areas that are dense with these serotonin 2A receptors. Now, the data suggests that various signs of enhanced neuroplasticity arise within 1 to 6 hours of administration of psilocybin, and it tends to taper off within 5 days. And this lasts for at least 1 month, as in the changes within those 5 days last for at least 1 month after the treatment of psilocybin. I'll now go on to where exactly these neuroplastic changes occur with psilocybin. I'll first highlight the abnormalities that have been observed in the structure and the function of the brains of those with people who have depression. Depression is obviously complicated and it's multifaceted, but at least as it relates to what argue the most significant component to the cognitive aspect, which characterizes depression, being that of a kind of negative state of perpetual rumination. Well, we can do a pretty good job at explaining what could be going on here with the neuroimaging studies that have been performed so far. Specifically, I'm going to speak of what is commonly referred to as the triple network model, which comprises 3 networks. Anybody who's interested in psilocybin may have already heard of this one. It's called the default mode network. The other 2 are the salience network and the executive network. Each of these networks consist of a group of interconnected brain structures which together form a functional system. So first, the default mode network. Its name comes from the fact that it's most active whenever we're not engaged in an activity which demands our attention. It's often active when we're in a state of wakeful rest, when we're kind of not engaged in anything particular. We often, unfortunately, engage in a kind of thought that often doesn't have an explicit goal in mind. And this often leads to kind of daydreaming, recalling memories, envisioning the future, thinking of others. This, as a collective, is often referred to as just simply mind wandering. And this is what the DMN is responsible for. Now, the executive network is the network responsible for executive functioning. And this is often needed for goal-orientated, cognitively demanding tasks. And the last one, the salience network, this can be seen really as the bridge between the DMN and the EN, the default mode network, and the executive network. It's responsible for modulating the switch between the internally directed cognition of the default mode network and the externally directed cognition of the executive network. Now, as it relates to these 3 networks in depression, depression is characterized by this hyper-connectivity and subsequent overactivity of the default mode network. And to add to this, we see this hypo-connectivity, so a reduction in connectivity between the default mode network and other higher order brain networks. And these include the executive network and the salience network. So we get this excessive mind wandering, which is caused by this overactivity of the default mode network. But you also have this reduced ability to divert attention away from this perpetual and often negative state of mind wandering as a consequence of these weak connections to the higher order networks that are responsible for doing this. So where psilocybin comes in, it's in its observed role in altering the connectivity of these networks. And interestingly, the serotonin 2A receptor is highly expressed in a pattern that resembles a map of the default mode network, the salience network, and the executive network, and the connections between all of them. And if you remember, I previously spoke about the fact that the neuroplastic changes occur local to where the serotonin 2A receptors that psilocybin works on are expressed. And as expected, this is what has been shown. After 1 day of psilocybin, what is seen is a decrease in the within DMN connectivity responsible for the negative rumination, and an increase in the DMN connectivity with the higher order networks, including the executive network and the salience network. And this would be responsible for the switching and directing cognition externally. Now, this is thought to be largely responsible for what is often referred to in studies as the global decrease in network modularity after psilocybin. This decrease in network modularity and an increase in flexibility, this may be important in the treatment of other disorders that are largely a result of this kind of cognitive inflexibility. Disorders such as OCD, autism, and others. I mean, this decrease in network modularity, what by definition also involves an increase in the communication between these networks with other networks, ordinarily outside their community limits. But it's this communication which likely leads to the therapeutic change in the individual that is suffering with these disease states. In a sense, it It works to free them up from a long-held pattern of excessive self-focus and rumination. So in relation to the administration of psilocybin, because the neuroplastic changes also occur in an experience-dependent manner, the experiences that people have during and around the treatment, well, they have a greater psychological impact than otherwise would have been the case. And so this is why the supplementation with psychotherapy, alongside other considerations to the treatment setting, is really an essential part to the dosing protocol and hopefully the therapeutic change that could occur. So the majority of clinical trials have administered 2 separate doses at a dose of roughly 25 milligrams, with each dose given roughly 3 to 4 weeks apart. Now, the subjects were either seated or lay down in these experiments with an eye mask on, and this is to avoid the distractions of visual hallucinations, which can actually be, they can be frequent with some, and they can also impede the therapeutic process. Now, it's odd to read this in studies, but music is also critical, and this is due to its effects on specifically gently guiding the emotional experience, which is often much more intense during a trip. Now, music advised in the studies is, well, the protocol advised with music in the studies is to start calm and then moving on to slightly kind of more upbeat, or at least kind of a bit of percussion during the peak effects around 2 hours in, and then kind of tapering it back down again to more calming music towards the end. And the trip usually lasts roughly 4 to 6 hours. Now, as it relates to the psychotherapy, generally in historic studies, the psilocybin assisted psychotherapy protocol consists of pre-treatment, treatment, and post-treatment sessions. Now, there were several conventional psychotherapeutic modalities that were mentioned, which were obviously modified for use in the psilocybin clinical trials. It's not particularly clear, and I wish it was, but most commonly used psychotherapeutic modalities were CBT and existential psychotherapy. Now, these conventional therapies were almost always in the pre or post-treatment sessions. During the treatment sessions, the therapist served as more of a guide, more so just providing the reassurance and gentle guidance if needed. And now the average number of pre-treatment sessions were about 3. Treatment sessions were, as previously mentioned, around 2, because there were 2 administrations of psilocybin. And the number of post-treatment sessions were around 6. So in sum, generally with 2 doses of 25 to 30 milligrams of psilocybin spaced a few weeks apart, with assisted psychotherapy and the appropriate setting during treatment sessions, these are the kind of things that will maximize the efficacy that psilocybin can have. So next up we have nutraceuticals. So first, zinc. So research into zinc was provoked by the observation of the strong connection between individuals with low zinc levels and depression. So far, zinc supplementation has shown to be effective in the treatment of depression, with the more convincing effects being when used in combination with the already gold standard antidepressants. Next up, there's acetyl L-carnitine. A major meta-analysis on this concluded that supplementation of L-carnitine shows a significant reduction in depressive symptoms when compared to the placebo groups. Next up, we have creatine. 1 gram to 5 grams of creatine monohydrate daily. This is an amino acid which is often known for its use with those who resistance train, because it can have really beneficial effects on recuperation. But there are some really promising results in relation to, well, from the literature so far, pointing to its mood enhancing effects. It's thought to be due to the role it seems to have in the dopamine pathway. Next, there's inositol. This is a sugar alcohol, which is abundant in the brain, with comparatively large doses taken daily. This is shown to be really promising in its effects in preliminary trials, but there aren't many of them. And then next, the omega-3 fatty acids, and specifically EPA. DHA has not showed to be effective in relation to depression. Now, the minimal dose recommended is relatively high, at 1,000 milligrams of EPA daily. Its observed positive effects on moods are thought to be a consequence of the anti-inflammatory properties that it could have. Next up, we have N-acetylcysteine, which is otherwise known as NAC. It's used commonly to reverse paracetamol overdoses, but this particular compound is emerging as having, a modest improvement in not just depression, but other mood disorders. Again, most likely due to its anti-inflammatory role. Next, we have bright light. Most of the emphasis so far within the realms of psychiatry has been on the effects that bright light therapy has on people with seasonal affective disorder. And it's shown to be very effective for people with this condition. Now, bright light therapy typically consists of someone sitting in close proximity to a 10,000 lux, which is just the luminance of the light, a 10,000 lux light box for about 30 minutes daily in the morning. Now, the causes of SAD are not completely understood, but what is clear is the overlap between SAD and typical depression, specifically as it relates to serotonin. Now, in SAD, there seems to be more specific abnormalities in the circadian rhythm shifts that, with healthy individuals, we rely on this shift when shifting between seasons. But what's interesting is bright light therapy appears to provoke an increase in the availability of serotonin also. This is why, although not a lot of quality research has been performed for its uses in other mood disorders, including unipolar depression, has been done so far, the research that has been done have been promising in terms of their results. Some of the emergent treatment options I have not included, and this was either because the evidence is still small, potential side effects, or the benefit with taking these is relatively minor from the literature that I've covered. This is not to say that taken sensibly, these don't help for some. I'm purely basing it on the experience that I have and the literature that's out there. Most importantly, the behavioural factors, the fundamental habits we all need to ensure we do consistently. I'm not going to expand on these in this video, although some info will be popped up on the screen. The reason being is that there is just so much to the importance of each and every one of them, and because of this they spill into many other aspects of our lives, and therefore they're not specific to depression. I will do a separate video on these, but I'll conclude briefly with saying that there really are no universal lifestyle factors that apply to everyone, which will ensure a happy and fulfilling life. There definitely are, however, universal factors that, will ensure a miserable and unfulfilled one, if not attended to. And on the screen are just a few of these. So that sums it up. If you found this video helpful, then please like and subscribe to my channel. My Instagram handle will be up on the screen, so feel free to contact if you have any questions. Most importantly, please feel free to also share this video, given the topic of this video, to others that you think it may help. And yeah, thank you very much for watching.